Welcome to Lecture 5 in our Pharmacology series. Over the past 4 lectures, you built a strong foundation. You learned the language of pharmacology, how drugs are classified, how they move through the body, and how they are legally controlled. Now we'll bring it all together in the most practical way possible. We will survey the medications you will actually see most often in day-to-day practice, and we'll learn how to read the abbreviations that appear in medication orders and on medication lists. Think of this lecture as the payoff for everything that came before. When you see a drug on a chart, you will now recognize its class, have a sense of what it does, and be able to read the directions attached to it. Let's go over our plan for this lecture. First, we'll tour the most commonly prescribed medication groups, organized so they are easy to remember, with a familiar example or two for each so the names start to feel real. Then we shift to dosage abbreviations, the shorthand that tells you how much of a drug to give, by what route, and how often. We will cover some of the common safe abbreviations you need to read orders confidently. We will also cover the dangerous, error-prone abbreviations that the Institute for Safe Medication Practices says should never be used, because knowing what to avoid is just as important as knowing what to use. We finish by tying everything back to your role. Here are our 5 goals for this lecture. First, recognize the most commonly prescribed medication groups so that the drugs on a typical chart look familiar rather than overwhelming. Second, connect common drugs to their class and general purpose, which pulls together the classification skills you learned in Lecture 2. Third, read common dosage abbreviations that describe how much of a drug to give, by what route, and how often, because these abbreviations appear constantly in orders and on medication lists. Fourth, and here's our safety priority, identify the error-prone abbreviations that should never be used because certain shorthand has caused real harm to patients and you need to recognize and avoid it. Fifth, apply all of this knowledge safely within your role as a medical assistant, staying inside your scope of practice while being a reliable safeguard. Notice how we stack this lecture. We start with the drugs themselves, move to the language used to order them, flag the dangerous shorthand, and finish with your responsibilities. By the end, you should be able to look at a common medication order, recognize the drug, and read the directions with confidence while knowing when something looks unsafe and should be clarified. This is exactly the practical fluency that employers expect, and it's a fitting way to complete our journey through pharmacology together. Before we dive into specific drugs, here's the map for our survey. It's easy to feel overwhelmed by the sheer number of medications that exist, but in reality, most of what you will see in a typical outpatient office falls into a handful of familiar groups. On this slide are the 6 broad areas we will tour. First, heart and blood pressure medications, which are extremely common because cardiovascular conditions are so widespread. Second, cholesterol medications and blood thinners, which often go hand in hand with heart care. Third, diabetes and thyroid medications, the 2 most common hormone-related treatments you will encounter. Fourth, breathing and allergy medications, from inhalers to antihistamines. Fifth, medications for infections, mainly antibiotics. And sixth, medications for pain, mood, and sleep, which cover a lot of ground in primary care. Notice that these groups connect directly back to the body systems we studied in Lecture 2 on drug classifications. This is intentional. You are not learning brand new categories today. You are attaching real, commonly seen drug names to the classes you already understand. As we go through the next few slides, don't try to memorize every single drug. Instead, aim to recognize the group a drug belongs to and recall its general purpose. That recognition is what makes a medication list readable and what lets you catch when something seems out of place. With this map in mind, let us start our tour with the heart. We begin with the heart, blood pressure, and blood, the single most common category you will encounter because so many patients manage cardiovascular conditions. These groups should feel familiar from Lecture 2, and now we are attaching common names to them. ACE inhibitors, which you can spot by the pril ending, treat high blood pressure and heart failure with lisinopril and enalapril as everyday examples. Beta blockers, ending in olol, treat blood pressure and control heart rate, such as metoprolol and atenolol. Diuretics, often called water pills, help the body shed excess fluid and lower blood pressure, and common examples include furosemide and hydrochlorothiazide. Statins lower cholesterol, and you will see atorvastatin and simvastatin very frequently, recognizable by the statin ending. Anticoagulants or blood thinners prevent dangerous clots, with warfarin being the classic older example and apixaban a common newer one. A few practical reminders tie back to earlier lectures. Blood pressure and pulse readings matter greatly for patients on these drugs, so accuracy when you room them is important. Patients on anticoagulants need attention to any unusual bleeding or bruising. And remember the name ending shortcut because it lets you predict the class of an unfamiliar drug on a chart. You don't need to memorize every single example. The goal is that when you see lisinopril, your mind immediately files it as an ACE inhibitor for blood pressure, and that quick recognition is exactly the fluency we're building today. Next are three groups you will see consistently: medications for diabetes, thyroid conditions, and digestion. Starting with diabetes, insulin lowers blood glucose and comes in several types that differ in how fast they act and how long they last, which is why timing insulin with meals matters so much for safety. Among oral diabetes medications, metformin is by far the most common first choice, taken by mouth to help control blood glucose. For the thyroid, levothyroxine replaces thyroid hormone in patients whose thyroid does not make enough, and it is typically taken once daily on an empty stomach. It's worth pausing on the note at the bottom of the slide. Metformin and levothyroxine are among the most prescribed medications in the entire United States, so you will encounter them again and again, and recognizing them instantly is genuinely useful. Finally, acid reducers treat reflux and heartburn. This includes the proton pump inhibitors such as omeprazole, recognizable by the azole azole ending we discussed earlier, and other reducers such as famotidine. Many patients also buy these over the counter, which connects back to lecture 4, so always ask what a patient takes on their own. For your MA role, the themes repeat. Confirm how and when a patient takes insulin, since timing errors are dangerous. Reinforce that levothyroxine works best taken consistently. And gather a full list, including over-the-counter acid reducers. Recognizing these few high-frequency drugs will make a large share of medication lists instantly readable. One last stop on our drug tour covers breathing, infection, and the mind, rounding out the medications you will see most in primary care. For breathing, bronchodilators open narrowed airways in asthma and COPD, with the albuterol rescue inhaler being the classic fast-acting example. Antihistamines relieve allergy symptoms, and common non-drowsy options include loratadine and cetirizine. For infections, antibiotics treat bacterial illness, and two you will see often are amoxicillin, a penicillin type recognizable by the cillin ending, and azithromycin, frequently prescribed as a short course, also called a Z-Pak. Remember from lecture 4 that antibiotics do not treat viruses and that checking for a penicillin allergy is essential. For the mind, antidepressants treat depression and often anxiety as well, with sertraline and escitalopram being very common examples. And recall that these medications may take several weeks to reach full effect, which is an important thing to reinforce with patients so they don't stop early. Finally, everyday pain relievers include acetaminophen and ibuprofen, which we discussed in detail in Lecture 2, including the caution about acetaminophen in the liver and NSAIDs in the stomach. That completes our survey. You now have a familiar example or two for every major group. When you combine this recognition with a name-ending shortcut, most medication lists become far less intimidating, and you can focus your attention where it belongs, on accuracy and patient safety. Now we shift from the drugs themselves to the language used to order them. Medication orders and prescriptions are written using standard abbreviations, a kind of shorthand that packs a lot of information into very little space. Instead of writing out a full sentence, a provider can state the amount of drug, the route it is given by, and how often to give it, all in a few letters. You will see this shorthand everywhere, on prescriptions, on medication lists, and in the electronic health record, so being able to read it fluently is essential to your daily work. Look at the right side of the slide, because every complete order really answers 3 questions. First, the amount, meaning how much of the drug, which is usually expressed in units like milligrams or milliliters. Second, the route, meaning how the drug is given, such as by mouth. Third, the timing, meaning how often it's taken, such as twice a day. When you can read all 3 parts, you can understand an order at a glance. There's one more reason this matters enormously, and it's the reason we will spend real time on it. Because these abbreviations directly control how much medication a patient receives, a misread abbreviation can lead to a serious error. So over the next slides, we will build your fluency with the common, safe abbreviations, and then we'll look at the dangerous ones that should never be used at all. Reading orders correctly is a core safety skill, and it starts here. Here are the common, safe abbreviations you will read most often, grouped by what they tell you. Start with route, meaning how the drug is given. PO means by mouth, and you will see this constantly. IM means into a muscle, and IV means into a vein, both of which you met in Lecture 3 on routes. Next is the amount. The abbreviation MG means milligram, a unit of weight for the drug, and ML means milliliter, a unit of volume for liquids. Getting these units right is critical because confusing them changes the dose. For the drug form, tab means tablet and cap means capsule. Then comes timing, which describes how often a drug is taken. BID means twice a day and TID means 3 times a day. PRN is a very useful one, meaning as needed, such as pain medication taken only when the patient has pain. AC and PC refer to meals, with AC meaning before meals and PC meaning after meals, which matters for drugs that must be timed with food. Reading a full order becomes easy once these click. For example, an order might combine an amount, the abbreviation PO and BID, to say take this much by mouth twice a day. Practice reading orders as 3 questions: how much, by what route, and how often. One important caution shown at the bottom. These are widely accepted, but every facility maintains its own approved list, so you always follow your workplace's official abbreviations. That discipline keeps everyone reading the same language safely. This slide is a safety priority, so pay attention. The Institute for Safe Medication Practices, a respected nonprofit devoted to preventing medical errors, maintains a list of abbreviations that should never be used because they have caused real harm to patients. Knowing what to avoid is just as important as knowing what to use. Let's go through the most important ones. First, the letter capital U or lowercase u for unit. Handwritten, it can look like a 0 or a 4, turning a small dose into a huge one. So you always write the entire word unit. Second, capital I, capital U for international unit, which can be mistaken for IV or for the number 10. So write international unit in full. Third, capital Q, capital D, and capitals QOD, old abbreviations for daily and every other day, which are easily confused with each other. So you write out daily or every other day. Fourth, and this pair is critical, decimal point errors. A trailing zero, such as writing 1.0, is dangerous because if the decimal point is missed, the dose reads as 10. So you just write the whole number with no trailing zero. Conversely, a missing leading zero, such as writing just 0.5, is dangerous because the decimal can be overlooked and read as 5. So you always add a leading zero and write 0.5. Notice the pattern. Every one of these avoids an easy visual misreading that could multiply or divide a dose by a large factor. For your MA role, the rule is simple and firm. Don't use these abbreviations yourself, and if you ever see one on an order that is unclear, don't guess. Clarify with a provider or pharmacist before anything is given. This single habit prevents some of the most serious medication errors that happen in healthcare. Let's put everything together by reading a real style order from start to finish, the way you will do on the job. Look at the sample order in the dark box at the top. It reads amoxicillin 500 mg, 1 cap, PO, TID. At first glance, that might look like a lot of code, but you now have every tool you need to decode it, so let's break it down piece by piece, which is exactly the habit to build. The first part, amoxicillin, is the drug itself. From our survey and the cillin ending, you should recognize it as a penicillin type antibiotic, which also reminds you to check for a penicillin allergy. The second part, 500 mg, is the amount, 500 milligrams. The third part, 1 cap, tells you the form and how many, 1 capsule per dose. The fourth part, PO, is the route, meaning by mouth. And the last part, TID, is the timing, meaning 3 times a day. Put it all in plain language, and the order says give 500 milligrams of amoxicillin as 1 capsule by mouth 3 times a day. That is a complete, readable instruction, and you decoded every part using the skills from this series. This is the fluency we have been building toward. When you can look at an order and confidently state the drug, the amount, the form, the route, and the timing, you can carry it out accurately, teach the patient clearly, and catch anything that looks wrong. Practice reading orders this way, one part at a time, until it becomes second nature. Before our final summary, let's take a moment to appreciate the full journey you've completed across these 5 lectures because you have covered a great deal of material. In Lecture 1, you learned the foundational language of pharmacology and how drugs are named, including the vital habit of charting the generic name. In Lecture 2, you learned how drugs are classified, along with indications, contraindications, and the powerful name-ending shortcut for predicting a drug's class. In Lecture 3, you followed a drug on its journey through the body with the ADME framework, absorption, distribution, metabolism, and excretion, and you learned why route and timing matter. In Lecture 4, you learned how medications are legally controlled, including the difference between prescription drugs, over-the-counter products, and supplements, and the 5 DEA schedules for controlled substances. And today, in Lecture 5, you connected real, commonly prescribed medications to those classes and learn to read the dosage abbreviations and orders, including the dangerous ones to avoid. Take a look at the final box. The result of all of this is confident, safe medication practice within your role. Each lecture build on the last, and together they give you a genuine working foundation in pharmacology. You should be proud of the ground you've covered, folks. This knowledge is not just for an exam. It's the practical toolkit you will draw on every day to keep patients safe, and that's the whole point of everything we've done here together. As we move on to the next lecture, you'll be learning how to do dosage calculations and safety measures to take your learning of pharmacology even farther. And now, finally, the summary. First, most of the medications you will actually see fit into a handful of familiar, high-frequency groups, so the world of drugs is far more manageable than it first appears. Second, the name-ending shortcut continues to serve you, connecting a drug to its class and general purpose at a glance. So a drug ending in pril is an ACE inhibitor, and one ending in statin lowers cholesterol. Third, medication orders state three things: the amount, the route, and the timing, using standard abbreviations like PO for by mouth and BID for twice a day, and reading them as though these three parts make any order clear. Fourth, and as a firm safety rule, you avoid error-prone abbreviations such as a capital U for unit or a trailing zero, writing the meaning out instead, and you clarify anything unclear rather than guessing. Fifth, your role comes down to recognizing and verifying, reading orders carefully, educating patients clearly, and documenting and escalating, all within your scope of practice. With that, you have completed the full pharmacology series. You built vocabulary, learned drug classes, followed drugs through the body, understood the laws that can control them, and today connected real medications to the orders that direct them. Congratulations on finishing this journey. Woo! We'll now move on to dosage calculations in the next lecture. Feel free to check out any of these references for more information on this lecture.